Rajiv asked me to talk about novel approaches to ammonia level, and I've been involved in a couple of studies, so I'm going to tell you about those. Here are my disclosures. So the background, which I think you all know, is that ammonia is suspected as important in the pathogenesis of hepatic encephalopathy. Elevated levels are believed to be a result of increased production and or reduced clearance, and thus attempts to remove ammonia may be clinically beneficial. So you all have heard about pretty much all of these compounds. I'm not going to go through these. You just heard an elegant talk by Rajiv about ornithine phenylacetate. The new ones that I'm going to talk about on the list here are glycerol phenylbutyrate, and the study that we presented almost 2 years ago now at the liver meetings that we lovingly call the Go Lightly study, which I hope you'll find interesting. So you've heard about the mechanism of action of phenylbutyrate, and I'm not going to review this again, I think in the interest of time. But the salient point is that this serves as a salvage pathway through excretion of PAGN. So this is a study that was published in April. This was a randomized, double-blind, placebo-controlled trial, including 51 sites, 35 in the United States and 16 international sites. Patients received 6 ml twice a day of glycerol phenylbutyrate or placebo for 16 weeks. They received standard of care background for treatment, and safety was carefully monitored with DSMB, as well as very carefully predefined stopping rules, such as an increase in MELD score, increase in bilirubin, and so on. Patients with cirrhosis were included. Patients had to have had greater than or 2 HE events within the past 6 months, one of which was more recent within the past 3 months. And the idea here is to recruit patients that were actively sick. If on rifaximin, they had to have 1 or more HE event after at least 4 weeks on therapy. Patients were also expected to be clinically stable on an established standard of care regimen. Patients were excluded with active complications of cirrhosis, TIPS, or significant comorbidities such that they were not expected to live through the duration of the study. The primary endpoint here was the percentage of patients with an HE event. This West Haven was used. Patients were expected to have a greater than 2 grade episode or a 1 grade increase in West Haven and Asterixis score if West Haven was 0 at baseline. Secondary endpoints included the total number of HE events, HE-related hospitalizations, and a carefully administered daily caregiver assessment using CHESS. So the study, this was a very intense study with many, many visits shown here over the 4-month period. There were fasting, ammonia, and PK studies done initially, and at the end of study there were phone calls performed in the middle. We basically were very diligent in following these patients. This is the cohort. There were 276 patients screened, of whom 98 were excluded and 178 were enrolled. The groups were evenly distributed. More patients in the placebo group completed the full course of therapy than in the glycerol phenylbutyrate group, probably because there was a slight discrepancy in the stratification of the degree of illness, which I'll show you, I think, on the next slide. 21 discontinued in the placebo group, whereas 35 discontinued in the glycerol phenylbutyrate group, and this was because they met stopping rules or other criteria. So here are the baseline features, pretty well matched, except, as I mentioned, for the proportion of patients with child C cirrhosis, of which there were more in the glycerol phenylbutyrate group. So a fairly substantial number more sickness in the GBP group. The results are shown here. So the primary endpoint was the percent of patients with an HE event. Shown here, placebo is 36%, 21% in the glycerol phenylbutyrate group, a reduction of almost 50%. Pretty much all of the endpoints were reduced by GBP, except for the total number of hospitalizations. Although this approached statistical significance, the total hospital days were different but were not significant, and there were no difference in reported AEs. This is a graph that shows the number of patients here on the y-axis over time on the x-axis, and you can see the total number of HE events, 57 in the placebo group and 35 in the glycerol phenylbutyrate group. So the summary is that fewer patients taking glycerol phenylbutyrate had an HE event as compared with the placebo. This is the primary endpoint. Patients taking GBP had fewer total HE events. There were fewer GBP patients treated who had a symptomatic day. GBP patients had fewer hospitalizations, although this did not reach statistical significance. The safety was comparable in the placebo and treatment arms. And I haven't shown you this data yet, but the ammonia levels also correlated with the risk of HE events. So this was an opportunity. So between this study and the previous urea cycle defect studies that Hyperion has performed, there are over 3,000 ammonia levels drawn in these patients. And so John Bierling and the Hyperion group got together and submitted an abstract which will be presented at the November meeting to look at the predictive ability of ammonia in neurocognitive dysfunction. And so this included 100 stable pediatric and adult UCD patients participating in those trials, as well as the patients from the trial that I just shown you. The analysis included, and I'm only going to show you just a teeny bit of data here, the relationship between ammonia assessed at baseline or as time normalized area under the curve, ammonia TNAUC here, and the risk and frequency of either hepatic encephalopathy or hyperammonemic crises in the patients with UCD. So this is a graph that shows in the red here the mean ammonia TNAUCs here stratified by either low baseline ammonia levels or elevated baseline ammonia levels, dichotomized at 1.5 times the upper limit of normal. And what you can see here is that if you have a lower ammonia level, your risk of an HE event, so the blue line shows the HE events here over on the y-axis over here, you can see that with a low level, your risk is much lower than it is with an elevated level. And this comes out to about a 3.5-fold increase here. The other thing of note is that the treatment, so glycerol phenylbutyrate, otherwise known as HPN 100, reduced the number of events. For UCD, the data are pretty similar. So again, shown here on this y-axis are the ammonia levels in the red, and then in the blue line the HAC rate. And here the risk is a little bit higher. So these patients are on treatment at all times, and they have fairly low levels or low risk at low levels of ammonia, which increases fairly dramatically when you get above 1. So it looks like there's a cutoff there as well. And this risk is around 4.5-fold. So ammonia seems to have a threshold effect. UCD being genetically prone to HAC, patients have a lower threshold than HE. That is from an acquired defect such as cirrhosis and hepatic encephalopathy. There is a high degree of similarity between the two diseases. You have hyperammonemia in both, similar clinical presentations as we all know, and a very similar historical therapeutic approach aimed at reducing ammonia. And I think this raises the question as to the role of reducing ammonia burden in patients with these diseases. So shifting gears then to further discuss the role of reducing the ammonia burden is a study that we presented again a couple of years ago and that is actually in press now. Will be out, I think, next week. This is a randomized controlled trial of lactulose versus PEG solution, and we used in our hospital Golightly, which is on the formulary, for treatment of acute HE. This was a pragmatic clinical trial. That was actually a lot of fun to do. Our hypothesis is that PEG would rapidly clear the GI tract of ammonia-producing bacteria and thus lead to more rapid improvement of HE than standard therapy, which was in our hospital lactulose. The aims were to compare clinical outcomes in patients with HE treated with PEG and standard therapy, and to determine, because we were concerned about this, the safety of PEG in this setting. The design was randomized, controlled. This was not blinded, of course, impossible to blind this. We performed this at Parkland Memorial Hospital at UT Southwestern. We were forced to obtain consent using a legally authorized representative, so we actually had a lot of fun with the IRB in that, but after jumping through a number of hoops, we were able to do that. Patients received 4 liters of PEG or standard therapy. Lactulose was prescribed per the attending physician and team as per their practice. We used HESA as the mode to measure HE. We performed this at entry and at 24 hours, and as I mentioned, we also watched safely, carefully. We did have a DSMB for this study. Patients were included if they had cirrhosis and acute HE. Again, we used a legally authorized representative. We excluded patients with other causes for altered mental status. There were a number of these. We also excluded patients who couldn't drink Golightly or receive fluids per NG tube, and those, again, who were critically ill were excluded. Primary endpoint was a change in HESA score at 24 hours. We estimated our sample size based on the reported literature, which, as you've heard throughout the course of this meeting, is not that outstanding. We estimated that the effectiveness of lactulose would be somewhere between 40 and 100%. Our best estimate was 55% lactulose, and we were a little aggressive with PEG and estimated a 90% response rate with that, leaving us a total sample size of 48. So this is the flow of patients. We screened a lot of patients, excluded a lot of patients, a very difficult study to recruit to. A lot of patients received, patients could only have had 1 dose of lactulose before entering in the trial, so if they got more than 1 dose, we excluded them. A lot of patients didn't have a legally authorized representative. A number of patients actually didn't have hepatic encephalopathy. They were septic or had something else. And then a smattering of other exclusions. Randomized 50 patients. This was an intention to treat study, and you can see here the flow of patients. The baseline clinical features were similar. In our institution, the mean age is 56 overall, and in each group. We have more men than women, as is typical, and the usual stratification of liver disease, mostly alcohol and hep C, with a ever-growing proportion of NASH. Our patients had moderately advanced liver disease with MELD scores of 17, Child's Pugh scores of 10, bilirubin, INR, albumin were quite well matched. So the results are shown here. Our change in HESA score was actually fairly dramatic. It was over a 2-fold difference. The lactulose group was 0.7 PEG, 1.5. The length of stay was also different, although this did not reach statistical significance. So this cut the length of stay, which is relevant in terms of cost, down significantly. So baseline ammonia, we did measure ammonia levels. We were not able to measure ammonia levels in every single patient because of the flux and flow in the hospital, but we were able to measure these in a majority of patients. Interestingly, so ammonia levels were elevated at baseline, shown here at 175 and 146, they actually decreased more in the lactulose group than in the PEG group, which was a little surprising to us. These are graphs that show on a per patient basis what happened in the lactulose group and the PEG group. So each one of these little squares represents a patient. At their, in white, their baseline HESA score, and then in dark, their, or on the left side, on the other side of this line, their baseline score, and then their follow-up score. So if they changed, they're white. If they didn't change, they're dark. And you can see that in the lactulose arm, a number of patients at HESA 3 didn't change, and a number at HESA 1 didn't change. Whereas in the PEG arm, all but 2 patients had a reduction in their HESA score. These 2 patients here who were 3. So overall, 52% improved in the lactulose arm, 91% in the PEG arm. This is a Kaplan-Meier curve showing the proportionate risk over here on the y-axis over time. This is time to resolution of hepatic encephalopathy, and you can see that the patients in the PEG arm resolved significantly more rapidly than the patients in the lactulose arm. So what about safety? We were very concerned about electrolytes. This, in my experience, is a big problem, particularly for lactulose. We see patients get hammered with lactulose and become hypernatremic. They did actually, in both groups, sodiums did go up a little bit, but it was not statistically significant between the lactulose and the PEG group. Creatinines really didn't change. Surprisingly, actually, creatinines went down. I'm not really sure how to explain that, but they did. And there was no difference in the 2 groups. So in summary then, PEG was associated with greater improvement in HESA scores at 24 hours. Many more patients who received PEG had a HESA score at 0, 10 versus 2, and patients receiving PEG had a shorter length of stay. PEG was well tolerated, as well tolerated as was lactulose, and there were really no adverse events in either group. So we speculate that PEG represents a novel approach to treatment with acute HE, and I use this in my practice now. The nurses don't like it, the house staff question it, but I find that it's quite effective. I do think that larger and more rigorous studies looking at other endpoints and biochemical markers are warranted. So with that, I'd like to acknowledge the co-investigators for the HALT-T glycerol phenylbutyrate study. This was a huge effort with many sites, many coordinators, and the Hyperion team, in particular Bruce Scharschmidt, who has shepherded this through. For our PEG study, our nurses and residents were fantastic, as well as our fellows. And then Bob Rahimi did yeoman's work on this. He got up in the middle of the night because we had to administer the initial HESA when we were called, and so we were doing these in the middle of the night and the follow-up ones at 24 hours because we timed these exactly 24 hours later. Amit Singhal, who helped consent randomized patients to help blind Bob from the HESA scores, and Jennifer Cuthbert, who was also supported. So with that, I'd be happy to answer any questions. Thank you.